welcome. My name is Dr. Chanel D. Guzman. I am in the office of the Dean's Office in the School of Public Health. I'm new to my position, so excuse that. I am here to acknowledge our sponsoring units today and to thank them for their contributions for this important event. When I call your name, would you please stand and be recognized? Dr. Douglas Strong, Chief Executive Officer. Deborah Childs, Chief Human Resource Officer. Tony Denton, I don't know if Tony is here today. Tony Denton, the Executive Director of the hospital and Chief Operating Officer. And to the academic units, College of Pharmacy, Dean Frank Ascioni. For the medical school, Dean James Williscroft, being represented by Dr. Ora Peskovitz, who is the Executive Vice President for Medical Affairs. School of Dentistry, Dr. and Dean Peter Polverini. School of Nursing, Dr. Kathleen Potempa. School of Social Work, Dr. Laura Lean. And the Dean of Public Health, Martin Filbert, who is the hosting dean and will provide the welcome and occasion. Dean Filbert.
Thank you, Chanel, and good afternoon. I'm delighted to be here with all of you today, and welcome to those of you who are joining us by live webcast. The Martin Luther King Jr. Symposium at the University of Michigan has evolved over the years into an important and thought-provoking time in the school year, not only for students, but also for faculty and staff and the public at large. I commend you all on coming out to join us for the Health Sciences Program, and I am confident that the conversation that we have here today will resonate with you in profound and lasting ways. The theme of this year's symposium challenges us to take the pulse of how we're doing in realizing the dream. We are succeeding on some fronts. We in the health sciences are finding new and creative ways to translate scholarly discovery into individual and population health. I know that through groundbreaking work on vaccines, health policy and administration, statistical genetics, chronic disease, environmental science, access to health care, and an array of other issues, the public health community has saved millions of lives and will continue to do so. It is an honor to be part of such an enterprise. I'm sure that Dr. Sherman James will explain some of the work yet to be done to achieve Martin Luther King Jr.'s vision of a society in which, quote, those that live on the outskirts of hope are brought into the metropolis of daily security, end quote. Health disparities are something that all of us who work in the health sciences struggle with. There is sobering evidence of unequal care and unequal access to care across the societal spectrum. At the School of Public Health, we are especially concerned with the poor and often minority populations who suffer disproportionately from illness and disability. Our mission compels us to create and disseminate knowledge with the aim of preventing disease and promoting the health of all populations. 12 years ago, Dr. James founded the Center for Research on Ethnicity, Culture, and Health here at the University of Michigan School of Public Health. CRESH develops new approaches to research and research training and prepares students to address the public health needs of an increasingly diverse society by providing a forum for basic and applied research on racial and ethnic differences in health across all departments within the School of Public Health. Rackham, our graduate school, now uses this center as the gold standard for showing how a research focus in a department serves to markedly increase diversity in the student body without incurring the concerns raised by Proposition 2. The new director of this important program is Dr. Cleo Caldwell, and the center has been well served since Dr. James' departure by Dr. Woody Neighbors. We still have many wounds to heal and much to learn about what we all can do to promote health and well-being. Today's health issues are complex and they require collaborations across campus and even around the world. Be assured that all of the health science units sponsoring this event today are dedicated to working together for the health of all. And now I would like to introduce my colleague, Trivalor Raghunathan, who is the chair of the School of Public Health's Department of Biostatistics and is the Associate Director of CRESH. He will introduce Professor Sherman James and help us warmly welcome him back to the University of Michigan. Thank you.
Thank you. First of all, I thank the organizing committee for giving me this opportunity to welcome my dear friend, Sherman James. And everybody remarked that, what is this about this tie and jacket? Because I never wear this tie and jacket. And this is because Sherman is back. And also my wife threatened yesterday that she's going to move all my jacket and tie to the basement closet because I don't use them and she needs more space. Now, when I was asked to introduce Sherman James, I said, gee, how can I do this in a short time period that I've been given? And how can I also get back at him for all the things that he did? So I said, okay, let me go travel down my memory lane to find out what are all the things that he did to me and how can I repay him. So it was a few days after I moved to Michigan in 1994, then survey statistician Jim Lepkowski asked me to tag along to a meeting called PIT meeting. So I didn't know what this PIT meeting was, and I trusted Jim Lepkowski that he wouldn't allow me to do some sort of, he wouldn't let me do some getting into PIT or something like that. So I said tag along and then negotiated these Ann Arbor Art Fair and reached this old School of Public Health. Now you can't recognize that building now. Negotiated all these stairwells with a lot of warnings saying that live virus, don't go there. And negotiated that and then reached this conference room. And then this first conference room, when I looked at it, the first thing that attracted me there was this solid piece of wood conference table, huge. And I'm a carpenter at heart, so all these things attracts me. And solid piece of chairs and shelves with glass doors with books, which I'm sure that nobody has ever touched for quite a while. And at the head, Sherman James was sitting there, and a few students sitting on the side. And as you know, that I think in Sherman's life, the students play a very, very prominent role. So you always find time for students. And I'm pretty sure that even this short while you are going to be here, you are meeting with a lot of students. And I'm pretty sure of that one. So the students were there, and after some introduction, we sat down. And then there was some discussion, philosophical discussion was taking place. There was an easel with a flip chart. And on the flip chart, there was this graph, schematic. So on a vertical axis was SBP written on it. So I knew that that was systolic blood pressure. I'm a biostatistician, but I know some medical terminology. So systolic blood pressure written on it. On the horizontal axis, ST written on it. And then there was the two lines. One line was a steep positive slope. The other one was positive slope, but with a little less steep. And then there was a JH equal to H written on it, and JH equal to L written on it. And after a while, in a discussion, I sort of thought that I could understand that ST stood for stress, okay? Systolic blood pressure, and then stress. And then I couldn't really know what this JH stand for. So I was raking my brain about all the biochemical markers that I knew, and all the things I knew. The JH didn't really strike me what this JH was. So there was a brief pause. I took this opportunity to say, what is this JH? And there I saw a glow in Sherman's face, and utter dismay in the student's face. The students thought that who this guy is coming here who doesn't know what JH is. Because that's a relationship between the student and the mentor is such a thick relationship that they can't imagine anybody not knowing what Sherman had invented. So there began my journey with the sociology, psychology, history, context, and anthropology. So he brought all these things together to bring this whole concept of John Henryism, or a John Henry, based on the legend of John Henry, the man versus machine contest. And then he invented a scale to measure the coping mechanism or the resiliency mechanism that person develops in response to the contextual, cultural aspects that one faces. And this led me to really understand the one aspect of this public health is about the social aspects of the public health. And I think in my life there are two epidemiologists who have given me what my view of current public health is. One is David Siskovic in the University of Washington, who really covered biological and behavioral aspects of it. But another one is Sherman James, who really brought the social, cultural, historical context on this particular notion of population health. And these two people have really developed my public health focus since then. So John Henryism, and then he took me on a tour of what kind of process he went through in terms of inventing those John Henryism scale. So I went through all this. Pitt County is a county in North Carolina, and then he took me to all these places where he interviewed the African American men and women there, and then thoughtful process that he used in terms of coming up with this John Henryism scale, and then I understood what this John Henryism was, and then how important a role he played. But although he's talking about the social context, his studies always included the broadest scope. So if Pitt County study, where we interviewed in 1988 and then 1993 and then the 2000, he always looked at the broadest scope. So he had the measures of behavioral aspects, biological aspect, social, cultural aspects. And it might be nice to go back to those individuals, and maybe in 2012, if the time permits, or if you have energy to do that, because I think it'll be fascinating to find out what happened with this economic downturn, and also the drift in our society towards more haves, and then leaving behind the have-nots. I think that could be an important lesson we could learn. So I was very delighted when he asked me to join the CRESH, Center for Research, Ethnicity, Culture, and Health, CRESH. And he told me some time ago that it means something in Portuguese. He's also very fluent in Portuguese, but I don't recall what it means I don't remember that, but I think he can tell me what the CRESH really meant. And again, as Martin said, that the CRESH really represent his thoughtful process. So he asked me to be the associate director for the quantitative research. He asked Amy Schultz to be the associate director of qualitative research, because it's more important that we get a very broad spectrum of a view on this role of ethnicity, culture, on health. And then, of course, true to his being, he asked Woody Neighbors to be the associate director for training and education, which has been a strong part of Sherman's life anyway. And then we were very sad when he decided to go to Duke University to become Susan Bennett King Professor of Professor of Public Policy, Distinguished Professor of Public Policy at the Duke University, partly to be close to his ailing mother at that time. So, but then I'm happy that the School of Public Health continues his tradition by having a wonderful director for this Center for Research, Ethnicity, and Culture and Health, and this is amazing individual, and you can read about his biography in terms of all the warm awards and so on that he has received in the paragraph, but transcending all those awards and accolades that he has got is really one of the careful, most comprehensive thinker about the role of various aspects on these health disparities, various factors affecting the health disparities, and a great mentor for the students and also for colleagues who can take a naive biostatistician through the journey and teach a person about these various factors affecting the health. I'm so delighted that the organizing committee chose Sherman James to be the Martin Luther King speaker here in this joint effort of all these different schools. And please join me in welcoming Sherman James to talk about Sherman.
Wow. Thank you very much, Raghu, for really a very, very generous introduction. I can think of no more perfect way to be welcomed back to the University of Michigan than to have my good friend and colleague, Raghu Nathan, introduce me on this wonderful occasion. So I really do thank you for those really kind remarks. Good afternoon to all of you. I would like to begin by congratulating Dr. Martin Filbert on his well-deserved appointment as the new Dean of the University of Michigan School of Public Health. I was the Associate Dean for Academic Affairs in the School of Public Health, working under the distinguished former Public Health Dean, Noreen Clark, when we successfully recruited Martin from Rutgers University in 1995. It was clear to me then, as I am sure it was clear to everyone else, that he was a real star. He did not disappoint. Dean Filbert is a first-class scholar, a visionary public health thinker, and a real gentleman. We can be sure that the Michigan School of Public Health will continue to thrive under his leadership. So again, congratulations, Martin. I also want to thank the Health Sciences MLK Program Committee for inviting me to speak at this 21st Annual Martin Luther King Jr. Symposium. I'm truly honored. And the committee asked just the right person, former Public Health Dean Ken Warner, to issue the invitation. I've always considered Ken a dear friend, and I accepted the committee's invitation without any hesitation, not only because of the honor, but also because of my friendship with and high regard for Ken Warner. It is good to see so many other old friends and colleagues in the audience today, and I really thank you for coming. A person of Martin Luther King Jr.'s intelligence, moral vision, and wisdom comes along perhaps once in a century, if we're lucky. For most Americans, and for many others throughout the world, certain images of him are stamped indelibly in our minds, such as those represented in these iconic photographs of triumph and hope at the 1963 March on Washington, or of his acceptance of the 1964 Nobel Peace Prize. But there are far too few photographs of King, the family man, playing with and enjoying his young children because of that fateful day in April of 1968. But Dr. King left behind a powerful legacy defined by an unshakable commitment to social justice for all people. And like our current president, an equally unshakable faith in America's promise. Today, and for one day in January of each year, we pause to honor his life and his work through discussions of how we might best continue that work, continue it, and also deepen and expand it. Because those of us assembled in this room belong to a national, if not global community of health scientists and healthcare professionals, each of us is engaged, directly or indirectly, in work aimed at healing or preventing wounds to the body, the mind, and the spirit, both of individuals and whole populations. Thus, our work is intimately connected to Dr. King's work, since his work aimed to diagnose and then heal the wounds that had been inflicted on the body politic through unjust laws and social policies that systematically excluded millions of the country's citizens from the benefits of first-class citizenship solely because of the color of their skin. Though my talk today focuses primarily on Black Americans, and more specifically on the changing health and social circumstances of Blacks in the U.S. South during the 1960s and 70s, I believe, and I hope that you will agree, that the insights we can gain by examining the health-damaging effects of the race-based social exclusion of Black Americans and the healing, the slow process of becoming whole again through their social inclusion, apply to other groups and also to other historical moments, including and perhaps especially the present. My talk is divided into 5 parts. Part 1 is an excursion through photographs back in time to the American South of the early 1960s, when the physical and social separation of Blacks and whites in practically every walk of life was rigorously upheld by local and state laws. The economic, social, and health deprivations that Southern Blacks suffered under that system are the wounds to which I refer in the title of my talk. Part 1 also summarizes through photographs the arduous and sometimes deadly struggle to overthrow that system, a struggle we call the modern civil rights movement. Part 2 summarizes some of the key civil rights acts, that is, anti-discrimination federal laws, passed by Congress in 1964 and 65, as well as some of the pro-poor social programs initiated by then President Johnson. Collectively, these anti-discrimination federal laws and these pro-poor social programs of the mid-1960s are the healing agents or the population-level medicine referred to in my title. Part 3 examines the ways in which the physical health of Southern Blacks dramatically improved, and within a remarkably short period of time, following the implementation of these progressive laws and social policies. In this section, I will also present data showing that the gains of Black Southerners during this period were not limited to physical health, but reached into areas that have important implications for how we might go about our efforts today to improve the health of all Americans while also slowing the growth of healthcare costs. Part 4 presents a theoretical perspective that I think will help us make sense of why the health of Black Southerners improved rather quickly in some areas but not others, and while racial as well as socioeconomic health disparities stopped narrowing in the early 1980s and began a disturbing widening trend which continues. Part 5, the concluding section, presents some ideas regarding how we might get some traction on the difficult problem of racial and socioeconomic health disparities that our country faces. Going forward, any progress we might make in this regard will require, at least in my view, a serious rethinking about how we organize our work and carry it out as health scientists and healthcare professionals, and how we go about training future generations to continue that work. So, let's begin with a photographic excursion back to the US South of the early 1960s. In urban areas of the South, there were laws that forced blacks to ride in the back of buses and to relinquish their seats to whites if a white person or the bus driver demanded it. As most of you know, it was Rosa Parks' refusal to give up her seat that led to the 1956 bus boycott in Montgomery, Alabama, a grassroots movement that launched Dr. King's career as a national civil rights leader. There was frank and overt racial discrimination in jobs and housing, and in retail services. Black children were forced to attend grossly underfunded and ill-equipped schools compared to schools attended by white children in the same community. Sources of liquid refreshment were also segregated. As those of you who have read Catherine Stockett's best-selling novel, The Help, know, extraordinary measures were taken to prevent the lips of white people from coming into contact with objects touched by the lips of black people. So I must tell you how relieved I was to find out when these odious white and colored drinking fountain signs were finally taken down across the South in 1965 or so, that the water that Southern whites had been drinking from their fountains tasted just as bad as the water that we Southern blacks had to drink. Not surprisingly, doctors' offices and hospital-based medical care was strictly racially segregated. That is, when within hospital care was available to blacks at all. For its time, the setting shown here is actually pretty advanced, in that it shows a separate obstetrics ward for blacks, or colored, as we were called back then. Indeed, it was not unusual in many Southern hospitals up through the early 1960s for all black patients, regardless of their healthcare needs, to be placed on a single hospital ward, which was sometimes located in the basement. And of course, when official segregation laws were not enough to keep blacks in their place, there was always the KKK rallies and parades, acts of pure psychological terrorism designed to maintain the system of white supremacy. In addition to the 1956 Montgomery bus boycott, other iconic moments in the struggle to overthrow racial segregation laws in the South included sit-ins at lunch counters by black and then by both black and white college students, designed to end racial segregation in retail services. The Freedom Rides of 1961 through 1963 sought to end racial segregation in interstate travel through the South via public transportation. Voting rights campaigns, most notably in Mississippi in the summer of 1964 and in Selma, Alabama in May of 1965, were arenas of protest where more than a few courageous people paid the highest price for their commitment to ending the then legally enforced political subjugation of blacks. The 1963 Children's Campaign in Birmingham, Alabama, was a key turning point in the movement. National television coverage of police brutality against black children and youth awakened the conscience of the nation to the depth of the racial problem in the South. An awakening that was reinforced by Dr. King's moving and memorable letter from a Birmingham jail. The 1968 strike of the Memphis sanitation workers, Dr. King's last campaign, put the spotlight on wage discrimination against blacks and the entrenched black poverty that this caused. Thus, by early 1968, Dr. King's focus had turned increasingly to the needless human suffering in America caused by chronic poverty. In 1964 and 65, the combination of President John Kennedy's assassination in November of 1963, the ongoing Cold War competition between the United States and the Soviet Union for influence in the newly independent nations of sub-Saharan Africa, and the moral force of the civil rights movement itself led to the passage of several major civil rights acts and social policies, including the 1964 Civil Rights Act, most notably Title VI, which prohibited discrimination and segregation by any institution that was receiving federal funds. The 1964 Economic Opportunity Act, which established the important program of Head Start. Head Start, as you know, provided comprehensive social, education, and health services for low-income children, specifically preschool children. The 1965 Social Security Act, which created Medicare and Medicaid, and which withheld federal funds from any hospitals that were practicing segregation. Hospitals had to qualify for certification. They had to demonstrate that they did not have racially segregated healthcare facilities in order to be recipients of Medicare reimbursement. And that particular requirement resulted in a near instantaneous desegregation of hospitals all across the South in 1965. The 1965 Social Security Act also increased funding for infant and maternal care programs serving poor pregnant mothers and their babies in both rural and urban areas throughout the country. And then finally, there was the 1965 Voting Rights Act, which gave black Southerners the power of the ballot. Although the black-white infant mortality, these federal legislative remedies to the festering social ills in the American South necessitated effective leadership by President Lyndon Johnson and a sufficiently strong spirit of bipartisan cooperation in both houses of Congress to overcome the opposition of long-serving and influential congressmen from the South. Between 1960 and 1970, black infant mortality rates improved notably across the country, as shown on this slide. Although the black-white infant mortality ratio at the national level in 1970 differed little from the ratio in 1960, 1.8 versus 1.9, the absolute reduction in infant death rates for blacks, namely a minus 11.7 between 1960 and 1970, was twice that for whites. As this slide indicates, the absolute reduction of infant deaths for blacks continued to outpace that for whites through 1980, suggesting that black infants were responding favorably to some form of external intervention. That external intervention was, as I noted earlier, the near instantaneous desegregation of Southern hospitals in 1965 in order to qualify for Medicare reimbursement. The seminal work by Che and Greenstone, two University of California, Berkeley economists, documented a dramatic decline in black infant mortality after 1965, especially among blacks in the rural South, as denoted by the red line on this graph. This next slide shows the rapid increase in the percent of hospital births with a physician present by race and by rural or urban location. After 1965, a fairly sharp increase in physician-attended hospital births for black infants in the rural South is evident. Nationally, a similar picture emerged for racial differences in maternal mortality, that is, deaths occurring to mothers during childbirth. Maternal death rates per 100,000 live births were shockingly higher for blacks compared to whites for all years shown here. But once again, we see that the reduction in the absolute number of deaths per 100,000 live births was much greater for black than white mothers during the 1960s and 70s. There appears to be a consensus among researchers that these declining black maternal death rates in the 1960s and 1970s resulted from an increase in federal funding authorized by the 1965 Social Security Act to hospitals and clinics for intensifying medical care to poor pregnant mothers and their babies. Che and Greenstone concluded the following. Between 1965 and 1975, black infant mortality rates declined more in the rural South than in any other region. That reduction in the black-white infant mortality rate was 2.5 times greater than in the US as a whole. The reduction in the black-white infant mortality rate in the rural South was strongly correlated with temporal increases in the proportion of physician-attended deliveries. In 1981, then Chicago-based cardiologist Richard Cooper and his colleagues were the first to document significantly greater absolute reductions in deaths across the country from coronary heart disease and stroke among blacks as compared to whites between the years 1968 and 1978. As shown in this slide, non-white women, over 90% of whom were black during this time period, showed an impressive 35.6% reduction in coronary heart disease deaths during the 10-year period. A similar story emerged for deaths from stroke, with blacks showing greater absolute reduction in death rates than whites. Although reductions in deaths from non-cardiovascular causes also occurred during this 10-year period, the reductions for blacks and whites on a percentage basis were much smaller than for cardiovascular disease. Noting the potential connection between psychological stress and hypertension that several studies have reported in the mid-1970s, Cooper and colleagues speculated that reduced stress among blacks caused by exposure to racist social conditions may have contributed to the decline in deaths from cardiovascular disease. However, they were much more inclined to attribute the reduced cardiovascular mortality to successful federally driven efforts to detect, treat, and control hypertension across the country in the early and mid-1970s with a specific focus on African Americans. And indeed, as shown in this slide, by the late 1970s, considerable progress had been made in treating hypertension, especially among women, both black and white, who suffered from this condition. In a 2008 publication, George Kaplan, now a University of Michigan professor emeritus of epidemiology, and his colleagues extended the seminal work by Cooper et al. By examining changing trends in black-white mortality ratios from cardiovascular disease in the US South versus the non-South for the years 1955 to 74. This slide which presents changing coronary heart disease death ratios among Southern Black women relative to Southern white women, shows that the excess coronary heart disease declined much more sharply during this time period for them, that is to say for Southern Blacks compared to Southern Black women compared to Southern white women in relationship to their non-South counterparts. A very similar picture emerged for stroke mortality. The Black-white mortality ratios declined much more in the South than in the non-South. Thank you. In contrast to heart disease and stroke, this slide shows little change over time in cancer death ratios for Black and white women. And it should also be noted that the Black-white ratios are much smaller for cancer deaths between 1 and 1.5 as compared to cardiovascular disease deaths where the ratios range between 2 and 6. You may recall that Cooper et al. Reported similarly smaller percent reductions in non-cardiovascular disease deaths for Blacks compared to whites, actually for both Blacks and whites during their 10-year study period. Now, this very informative graph by Kaplan and colleagues shows that the decline in the all-cause mortality ratio for Southern Black versus Southern white women between 1965 and 1974, just 10 years after the passage of key civil rights era legislation, was greater than in any other region of the country. Specifically, the all-cause mortality ratio for Southern Black and white women, Southern Black women in relationship to Southern white women, declined by almost 60% as compared to 40% or less in other regions of the country. A very different picture altogether emerged for males. That is, during the 10 years after 1965, the decline in all-cause mortality for Black men as compared to white men, there was no differential change in any region of the country. Now, Kaplan and his colleagues speculated that one potential explanation for the greater improvements in cardiovascular health for Black women as compared to Black men, for example, was the growing equality in median personal income between young adult Black women as compared to young adult white women, in contrast to little movement toward income inequality for Black men as compared to white men. As shown here, Black and white women had roughly equal median personal incomes by 1980, whereas Black men still earned only about 65 cents on average for every dollar earned by white men. Improvements in physical health were not the only important area where African Americans registered progress in the 1960s and 70s. The test scores of Black children in elementary, middle, and high schools on standardized educational achievement tests also showed impressive improvement. And again, the improvement was greater in the South than in other regions of the country. This slide shows average gains in reading and math test scores expressed in standard deviation units among Black children on the widely used National Assessment of Educational Programs, Progress, or NEEP. Test scores of Black children in the Southeast improved about 0.8 of a standard deviation between the early 1970s and the early 1990s, in contrast to Black children in the Northeast, where test scores improved about 0.35 standard deviation units. Test score gains were second highest in the West, but it is worth noting that the NEEP, in contrast to the US Census, for example, includes Texas and Oklahoma in the West, rather than in the South. The authors of this particular study speculated that the regional differences in test scores and test score gains shown here could reflect the fact that during this period, schools in the Southeast became less racially segregated, whereas in the Northeast, they became more segregated. It is important to mention here that even though there was some narrowing of the educational achievement gap between blacks and whites during the 1970s and 80s, that gap remained disturbingly large with whites throughout that period. But like the improvements in physical health, there was a greater narrowing of black-white educational test scores during this particular period than had ever been seen previously. Now, the authors of this particular study drew the following conclusions with respect to three questions. One, what happened? Between 1971 and 1996, the black-white test score gap in reading and math narrowed by 0.2 to 0.6 standard deviations. When did it happen? Blacks entering school in 1968 did little better than those entering in 1960. But blacks entering between 1968 and 1980 made large gains, larger than those entering after 1980. What explains the gains? Positive changes in family characteristics, such as marital status, increases in income, increases in education, home ownership, explain nearly all of the white gains, but little of the black gains. Black gains might be explained, they said, loosely, by the civil rights, war on poverty model, and the school-based model, by which they meant smaller classes and more demanding courses in middle and high school. So, what might we plausibly say at this point about the specific ways in which civil rights era legislation positively affected the life circumstances of black Americans, especially black Southerners, from the mid-1960s through at least the early 1980s? One, there was an increased access to medical care, which in all likelihood was primarily responsible for the sharp reduction in black infant and maternal mortality, and also for the important decreases in cardiovascular disease mortality, owing, arguably, to the increasingly successful treatment and control of hypertension, particularly among black women. Two, passage of the 1964 Civil Rights Act opened up new opportunities for blacks across the country to experience more rapid upward social mobility, enabling them to earn higher wages, purchase better housing, eat healthier diets, etc. In addition, in the South, day-to-day life was less characterized by extreme social exclusion and disrespect. Black adults began to be addressed by whites with titles of respect, like Mr., Miss, Mrs. And they could register at hotels and sit on buses and in restaurants wherever they pleased without fear of harassment or violence. Now, so then I would perhaps suggest that the need to be hyper vigilant in day-to-day life diminished considerably. Whether all of these changes added up to enough reduced physical and psychological wear and tear, or reduced weathering, as our colleague Arlene Geronimus might put it, to actually reduce the incidence of cardiovascular disease among black adults must be left to speculation. But the idea that it might have done so does not strike me as wholly unreasonable. Now, as many here in this audience know, after a 15-year period beginning in the mid-1960s of a narrowing of racial and socioeconomic health disparities, the gap began widening again in the early 1980s. And this happened because health improvements of the kind I have discussed in this presentation greatly slowed down for the poor and the less well-educated of all races by the early 1980s. But these health improvements continued among the more affluent and better educated members of our society. Which leads us to this question. What drives changes over time in racial and socioeconomic health disparities? Is there any order or theoretical coherence in the apparently disparate facts that somehow aggregated to produce the welcome reductions in racial health disparities, especially in the American South, during the 1960s and 70s? Reductions which then stalled beginning in the 1980s. Lincoln Phelan's Fundamental Social Causes of Disease framework may help us understand what the apparently disparate facts, increased access to medical care among blacks, upward social mobility, improved test scores among black children, have in common. When we develop the ability to control disease, the benefits are distributed according to resources of knowledge, money, power, prestige, and beneficial social connections. Those who have such resources, Phelan and Link say, consequently experience lower mortality rates. Health disparities are the result. Could it be then that the vast and legally assisted disparities in knowledge, money, power, prestige, and beneficial social connections between whites and blacks in the Jim Crow South prior to 1965 was the fundamental cause of the disturbingly large racial disparities in disease and death that characterized the pre-civil rights era? While the progressive laws and social policies of that era did not, indeed could not, in a mere 15 years, wholly eliminate centuries-long health disparities, these progressive laws and social policies demonstrated what is at least possible given adequate time and resources. In addition, the Fundamental Social Causes of Disease framework helps us to see how the mid-1960s anti-discrimination laws and pro-poor social policies effectively accelerated black access to knowledge, to useful knowledge, higher incomes, power, especially political power, prestige, particularly job prestige, and beneficial social connections, all of which we might reasonably suggest combine to initiate a healing process. The Fundamental Social Causes of Disease framework makes two very important predictions. One, racial and socioeconomic health disparities will not be evident for diseases which we have not yet learned to prevent or control. Brain and ovarian cancer are two examples. Since group differences in knowledge, money, and prestige are largely irrelevant to who gets sick from these disorders. Two, during historical periods when U.S. racial and socioeconomic group differences in access to these fundamental resources narrow, as for example, from the mid-1960s through the 1970s, group differences in these key resources, health disparities will decrease. However, when racial or socioeconomic group differences in these key resources widen, as has been the case in the US and much of Europe for the past 2 to 3 decades, health disparities will increase. The available scientific evidence supports these two predictions remarkably well. The fundamental cause perspective properly notes that there are indeed some diseases which are not socially patterned by race and socioeconomic status. But such diseases are relatively rare especially in advanced technological societies like the US. Higher levels of education and income lower risk for a very, very large number of diseases and unhealthy behaviors. And on balance, research suggests that the association between high levels of education and good health is indeed causal and not something that is wholly secondary to unmeasured factors. This issue brings me back to my earlier discussion of how educational achievement test scores of Black children increased, in several instances much faster than those of white children in the 1970s and 80s, and considerably above the test performance of comparable age cohorts of Black children who were tested back in the early 1960s. The educational achievement gap between Black and Hispanic students, however, as compared to white and Asian American students, remains large and is a cause for real concern, given the kinds of technical knowledge and skills that the 21st century global economy now demands. But looking beyond the clearly important issue of domestic and global labor market competitiveness, if higher levels of education are somehow inherently protective against much premature disease and death, then it seems undeniable that those of us in the health field should be paying much more attention to what is happening to America's children in our public schools, especially the large number of minority children who are born into impoverished families and who grew up in impoverished neighborhoods where the public schools are simply unable to give them and their families the kind of support that they need in order to grow into healthy, happy, and contributing members of society. Though it is not inevitable, being born into an impoverished household in an impoverished neighborhood usually translates into an unhealthy start in life, one that puts a child on the fast track to develop lifelong unhealthy lifestyles, as well as childhood and later on adult diseases that keep all too many families impoverished while simultaneously driving up national healthcare costs. I therefore invite you to seriously consider the proposal that we health scientists and healthcare professionals should prioritize early childhood development as perhaps the best way to get some traction in our otherwise stymied efforts to improve the health of all Americans while simultaneously reducing racial and ethnic health disparities. In two very thoughtful reviews of the literature on the effectiveness of very early childhood development intervention programs aimed at improving cognitive and non-cognitive skills of economically disadvantaged children, the authors concluded the following. Very early intensive interventions with relatively long periods of duration may have larger and longer lasting effects on child cognitive development. Investing in disadvantaged young children is a rare public policy initiative that promotes fairness and social justice, and at the same time promotes productivity in the economy and in society at large. The advantages gained are sustained best when followed by high-quality learning experiences. Their conclusions were based on pretty solid evidence from long-term follow-up studies showing that intense early childhood interventions of sufficient duration, that is beginning in infancy and perhaps continuing through middle school, produce a range of positive benefits for disadvantaged children. And based on long-term follow-up of economic outcomes in the well-known Perry Preschool Project, good economic returns to society as well. Importantly, one well-designed study of childhood mortality outcomes among children enrolled in Head Start programs, and remember Head Start was initiated in 1965 under the amendment to the 1935 Social Security Act. But in this really well-done study of mortality outcomes among children enrolled in Head Start programs in the poorest 300 U.S. counties, which made them eligible for augmented federal funding, the researchers found that these children had lower mortality from treatable childhood conditions such as asthma, measles, and pneumonia than children enrolled in Head Start programs in counties whose poverty level was not high enough to justify augmented federal funding. Now, it goes without saying that no real progress can be made on the issue of raising educational achievement levels, and I would argue, therefore, increased health capital of America's poorest children, of color especially, unless we first solve the very thorny problem of racial and ethnic residential segregation. But framing this discussion within the context of the need to do what is best for the country's children, all of the children, may help to diffuse at least some of the overheated rhetoric that currently permeates our national discussions about the responsibilities of government versus, if you will, the responsibilities of individuals and families. In conclusion, I come away from this particular inquiry into the relationship between public policies and the health of the American public with a new and sobering appreciation of the power of government, on the one hand, to inflict wounds on the body politic, especially on its most vulnerable members, or on the other, to take concerted actions to heal such wounds, if they cannot be prevented altogether. Our work as health scientists and healthcare professionals would be a lot easier if we had partners at all levels of government who see the prevention and the healing of wounds to the body politic as their primary mission. Whether this can or even should come to pass is a key question in the current historical moment. How that question is answered will determine whether our health disparities reduction work in this new century will become easier or immeasurably more difficult. And I believe it is a question that requires our active engagement as scientists, as healthcare professionals, and of course, as citizens. I thank you. I hope we have some time for questions, comments.
Two comments. One, I'd like to get your prognosis for the future, given the fact that it seems like government is intent on capping the debt, and the same programs that you referred to as being healthy for us look like they're the most vulnerable for elimination to decrease debt. So how do you see that social model, your prognosis for the immediate future on healthcare disparity? Is question one. And question two that I'd like you to comment on is, when we do clinical trials, we usually expose black and whites to the exact same therapies. And sometimes despite that, they're getting, a protocol type approach. There are big differences in outcome. There's still racial disparity when they try to treat people with the same disease the same way. Suggesting that there is something else beyond social, because we've accounted for the delivery of the healthcare. So one, again, is more prognosis, and then adapting this model that you have of social to the instances where the gap persists despite the ability to deliver healthcare in a racially equal way.
Well, I thank you for those two questions. Let me try to answer the second one first. It's not entirely clear to me that we, even in clinical trials, maybe in clinical trials we come closer than anywhere else in delivering equal clinical care for racial groups. But there are really some very subtle things that go on in the clinical encounter between physicians and patients that we have not yet fully understood. And this is one of the areas of really intensive research now, the clinical encounter and the racial dynamics, the racial and class dynamics of the clinical encounter. So that even though physicians may prescribe, the very same medicine, may not be taken, as prescribed. Importantly, there may be environmental and familial circumstances that interfere really with the efficacy of the medicine. So there are so many differences, in the life circumstances of people of color, particularly the most economically disadvantaged people of color and whites, that it's hard, I think, for us to confidently conclude that we have equated all of the conditions that might affect clinical outcomes. I'm thinking about, the very important hypertension detection and follow-up program of the mid to late 1970s, which I'm sure you are very familiar with, Ken. And one of the things that program did, this is when they were sort of testing the efficacy of step care treatment for hypertension on a community basis. They demonstrated in clinical trials, in the VA and so on, that it worked. But now the question is, can you take that model to the community? And being cognizant of some of these sort of extra clinical factors, these sort of social and environmental factors that might interfere with getting a clear answer to the question, does this work on a population level basis? Can we actually reduce cardiovascular disease mortality in the community if we can get people who are hypertensive on effective therapy? Well, what they had to do in order to test that was to eliminate all the barriers that people typically encounter in order to actually get the medicine. Transportation barriers, economic barriers, and they assigned, if you will, sort of caseworkers to help, in this case, particularly low-income Black Americans who suffer disproportionately from hypertension, to help them with their psychosocial issues so they could actually concentrate on the medication. And when they were able to put all of those things in place, reduce all of those sort of extra clinical barriers, you know what happened? They actually showed in less than 5 years that they could eliminate the socioeconomic gradient, the education gradient in cardiovascular disease mortality. It went away. Now, was that a drug trial? No, it was not really a drug trial. It was a trial of our healthcare system. It was such a successful trial that they ended it early. So I just think that the same drug might have differential physiological effects because of all of these sort of unmeasured and oftentimes unknown factors that affect how well that drug is actually going to be taken up and utilized by the body. To your first question, in this moment, I am not optimistic. I'm not optimistic. We will have to see. I think the first test case will be, about health care, the repeal of the health care reform. I mean, obviously it's not going to succeed because Obama is not going to let it. The Senate is not going to go along. Obama would obviously veto it if it did. So I think that issue is particularly settled, and that's really a very important kind of development because, why? It really gets back to this notion of the fundamental causes of disease, right? It's making available now access to health care for people who, in all too many instances, don't have it. So it's working to reduce that particular barrier. So if this can take root, and begin to work in ways that we all hope it will work, and we're not going to know for a number of years, right? We won't know for a number of years. And so all the heated political rhetoric now about, what it is and how it's going to fail and how it's going to drive up healthcare costs, we just don't know. We just don't know. So I want to come back to my concluding point in my talk, which doesn't have to do with health care per se, except in an indirect and sort of a long-term way. If we're going to do something about reducing racial and socioeconomic health disparities in a permanent way in our country, we've got to start early. We got to start early. We have to really focus now on intervening with infants in early childhood, really mobilizing ourselves to be in partnership with people that we don't normally interact with. Teachers. Teachers can't do it all. They can't do it all. We are asking too much, I think, of the public school systems, particularly in some of the more difficult environments. And unless we find ways to partner with them, to help them do their job, and to help the parents be more effective partners with the teachers, we're going to continue to have the kinds of problems that are currently overwhelming the healthcare system. This is the best way to improve population health, to start early. To begin a national conversation, I would say, Ken, about something that most Americans think is important, and that's education, and the education of children. To frame what we need to do in that way for our children. It would be hard for, it seems to me, anybody to argue that that's not a good thing to do. There is so much at stake. It is the morally right thing to do. It is the economically most sensible thing to do. It is what we all care about. So if I have any optimism at all, momentarily, it is that eventually we can get to that issue. And that was what I was referring to in the first part of my talk when I said the implications of what we know about the effectiveness of early childhood interventions, and the evidence is really, really very strong, suggests to me that we need to start doing something differently in the health field. We need to start training future generations of health scientists and healthcare professionals differently, because what we're doing now is not working with respect to the healthcare, with respect to health disparities and healthcare disparities. It's not working. We need a new model. Other questions, some comments? Yes.
Yeah, I would.
Good to see you, Jerry.
I would ask what you think of our political voice, and it seems like those of us who may share this concern are underpowered, and or maybe I've just lost part of the framework. But
Underpowered.
I don't think our voice is heard on these issues very well. I don't think the scientific community is well represented.
Yeah, well, that was why I said in my very last sentence that we need to become more actively engaged.
With what framework?
Well, I don't know. I mean, I think it's going to depend. I don't have the answer to that. I don't have a blueprint about that. I mean, what pharmacists do might be very differently from what pediatricians do, what obstetricians do, what cardiologists do, what dentists do. Might be very different. I don't think there's a one-size-fits-all approach to this. You know, when I said that we set aside one day in January of each year to think about how we can carry on the legacy of Dr. Martin Luther King. And so I've invited you to start thinking about how we, in our respective health disciplines, might carry on that legacy in a new way. So I would not presume to know what the right approach is. for all of the different fields that are connected. I just know that we need to do that. And I will not permit myself to feel disempowered. Yes.
This is Glenn Nelson, and I'm on the school board.
I'm sorry, I can't hear.
I'm Glenn Nelson. I'm on the school board here in Ann Arbor. Very much appreciate comments. I will make comment that in Michigan, we are reducing our investment in K through 12 education as a percent of personal income every year since 2002. And locally, when we put a millage on the ballot last November 2009, to put some of that money back into the system, it failed. So there are great things we can do locally and in our own state because we're really on the wrong direction on the investment in children equation in this state and in this community.
And not only in Michigan, I think that applies really across the country, and it's an unfortunate development. And I can't wait until, we start having that national conversation. And once I would like to believe that once sort of the healthcare issue gets put to rest, and we see what kinds of programs are on the chopping block, and the K through 12 funding is at risk, and it's at risk in North Carolina. It's at risk in North Carolina. I think this is a really, really disturbing development. So much is at stake. And as I said earlier, it directly impacts everything that we do in the health field, everything. Stephen.
Sherman, this is an amazing time in data. There was a book that came out more than 10 years ago by Charles Murray and Richard Ernstein, Bell Curve. And it categorized different groups, Caucasian, African American, Chinese, and said that there was statistically significant and persistent intellectual aptitude differences between the groups. The book was actually circulated across the campus because the newspapers wanted to know what people thought about this. What strikes me as amazing is that the data that you presented didn't make its way into this kind of literature. But I think that this kind of literature has had a lasting effect on the way that people view educational attainment. Is it to say that people remember the negative more strongly than they remember the positive, the possibilities? So my question is, how could two individuals who made themselves out to be legitimate scientists completely forego the kind of data that you're talking about? And what can we do on a wider scale to accentuate positive lessons so that those can make social progress?
Well, as you know, tomes have been written, critical of the bell curve. Precisely, noting gaps, in their literature review. To the degree that there are, and we don't really know what IQ measures. Is there a genetic component to what is measured by IQ, by what is measured by, what we call intelligence? Probably. I know when I'm in the presence of genius, put it that way. Whether those differences in quote-unquote innate intelligence are socially patterned by race, I think is still up for grabs. What produces high IQ scores? Well, having highly educated parents. Now, that doesn't sort of settle the issue of, the biological component of that. But what I think it does emphasize, is the importance of these early life experiences, being read to, being taken to museums and concerts, early life exposure, talking to babies, talking to young children. There was a study that received actually a lot of press recently, that the number of words in the vocabulary of well-educated, children, white children born into well-educated families, is higher by an order of magnitude than the number of words in the vocabulary of a poor child, particularly black child. Order of magnitude. And the simple explanation for that is that these better educated parents are talking to their babies, their kids. Now, if you've got a pretty rich vocabulary, you're going to do pretty well on reading achievement scores and on IQ tests that test vocabulary and conceptual abilities and so on. You're going to do well. And so my point was that, I am not ready to say that, I'm not ready to accept the idea that black children have some sort of ceiling in terms of how far they can go with respect to cognitive development. I'm not prepared to accept that. I think we just need to start earlier. And we need to have the educational experience focus on more than just test scores, but focus on imbuing young children with a desire to learn, a love of learning, such that going to school becomes a positive thing, something that they look forward to do, and that it is not an arena where they're told that they're not good enough, where the expectations for success are set so low that they aren't inspired to try to do well. I won't have time to go into it because of time constraints, but there's a really rich literature on Stereotype Threat, which some of you may know, done by the distinguished social psychologist Claude Steele, indicating that black high school students and black college students, even at elite universities, Michigan, this is where a lot of that work was done back in the early 1990s, Stanford and so on, perform poorly on, let's say, tests assessing the vocabulary or assessing their math competence, if they are given the impression that the test has something to do with race and racial differences. They freeze up, they become anxious because they see it as something that is going to assess whether or not they are as smart as whites. And these are kids with very high SAT scores. Very high SAT scores, get into the elite universities. And so, but then when the experimental situation does not sort of bring race, however subtly, into the examination situation, there's no difference in terms of their performance on these tests compared to whites. No difference. But if race creeps in, however subtly, it diminishes their performance. Now think about that. Think about that. How does that work then with respect to IQ tests? My God, who doesn't know that blacks aren't supposed to be as smart as whites? Kids know that at age 4, 5, 6, or 7. Black kids know that. So now they're given a test, and it's sort of infused with this notion of race. How does that affect their performance? So I just think that there are so many complicated things that go into this equation that we don't really understand yet. And we need to attack everything that we think might be interfering with the love of learning on the part of young minority children. How are we doing for time? We're okay, huh? Pretty much there. Do we have time for one question or one more question? One short question, one short answer, I promise. The gentleman in the back.
Sir, I would like to give a caution and also an observation. The caution is we often will focus on the South, but I don't know what the South means. My mother lost a set of twins in 1950 because the white ambulance would not take them to the hospital.
Yeah.
That was in Ohio. And the observation was, you showed statistics as to how there have been great improvements between 68 and 85. After King was killed, there was a great spike in the number of African Americans who were allowed to go to college the following year. That hope helped to see their children so that they could be more cognizant of what is necessary for good health. And I think those are things we need to weigh.
Right. I certainly agree with that. I taught at the University of Michigan for 14 years, and I've certainly lived, in many different places outside of the South. And I know that the problems that, we all are concerned with are really national problems. But I wanted to focus on the experience of blacks in the South to sort of illustrate the importance of public policies, and as a tool to really facilitate progress in terms of improving the health of the entire population and reducing health disparities. That's where the data are available. Do we need studies in other parts of the country that speak to the conditions of the current moment? You bet we do, and I hope that we get them. Well, I thank you very much for your attention.